You're listening to the Assembly on Pediatrics podcast, brought to you by the American Thoracic Society.
Welcome to the ATS Pediatrics podcast. My name is Dr. Matt Wong. I'm a pediatric pulmonologist at the Children's Hospital of Los Angeles.
And my name is Dr. Ina St. Onge. I'm a pediatric pulmonologist and the CF Center Director at Maine Health in Portland, Maine, and I'll be co-moderating with Dr. Wong.
Today, we are going to bring you a conversation on an official American Thoracic Society workshop report titled Research Priorities in Pediatric Asthma Morbidity, Addressing the Impacts of Systemic Racism on Children with Asthma in the United States. This report was published in the Annals of the American Thoracic Society in October 2024. Our two guests for this podcast are members of the working group that created this report, Dr. Monica Federico and Dr. Stephanie Lovinsky-Desir. In this podcast, we discussed how the workshop report came to fruition. We defined important concepts raised in the report, such as systemic racism, as well as talked about redlining and its lasting impacts. Lastly, Dr. Federico and Dr. Lovinsky-Desir discussed some major takeaways from the report, including establishing relationships with stakeholders and their advice on engaging in meaningful research in this space. Please enjoy.
I'm Monica Federico. I'm a pediatric pulmonologist at the University of Colorado, so Children's Hospital Colorado in Denver. I'm a professor of pediatrics, medical director of the asthma program, and of population health for Children's Hospital Colorado.
I'm Stephanie Lovinsky-Desir. I'm at Columbia University Medical Center in New York City, and I'm the chief of our pediatric pulmonology division, as well as an associate professor in environmental health sciences.
Thank you both for joining us today. I'd like to start by asking if you could talk about the background behind this working group report.
John Gaffin and I are lucky enough to be part of the Severe Pediatric Asthma Coalition, put together initially by Eric Forno. And so as part of that work, we talked about working with the American Thoracic Society to talk about pediatric asthma and the disparities that we see in pediatric asthma. So initially, our thought was to put together a workshop with experts to talk about how to forward research and disparities seen across different groups in pediatric asthma. And as we talked to experts like Stephanie Lovinsky-Desir, Sanday Okello, and others across the country, we really thought by just talking about social determinants of health or health-related social needs, then we were missing the upstream and more important cause of the differential distribution of those social determinants of health, which is systemic racism. So as we thought about that, we really changed what we wanted to apply for, and then the application for approval for the American Thoracic Society workshop for this work to address the impacts of systemic racism on children with asthma came together with Stephanie, Iseretta Riley, Jonathan, myself, and then we were able to assemble a diverse group with variable levels of expertise, with variable interests in terms of their expertise, whether it be adult work, whether it be sociology, whether it be systemic racism. And we had parent and patient representatives as well. So we pulled that group together to address what we felt like was the upstream cause of these disparities, and then to think carefully about how we might be able to even suggest how people can do work that would then inform policy to change the underlying problem.
Wonderful. Thank you. Anything that you'd like to add, Dr. Lovinsky?
No, I think Monica did a great job of kind of summarizing how we all came together. And I think the biggest strength of putting a workshop like this together was just how multidisciplinary it was. It wasn't just a group of pediatric pulmonologists who study asthma who wanted to get together and talk about what our next projects should be. It was much more intentional about bringing in social scientists and people who are working in the community and people who are not just pulmonologists, but general pediatricians. And I think that made for very rich discussion. And I think that's why our workshop report is so comprehensive and has a lot to offer our community.
Wonderful. And I think it really echoes sort of practicing what you preach with community engagement and getting those patient and family representatives and so many disciplines so that everyone's voice is as representative as possible. I think if you could talk a little bit just about how the actual report came together and maybe a timeline of how long have you been working on this and all the different facets that came into putting this together.
It took us a long time to put all this together. Let's see. So we really started talking about it and thinking about it over about a year. Then we were able to work with Stephanie and Izaretta and John, and I put together this group of our list of who we wished would participate. And we were incredibly lucky that most people said yes. And so over a year, and it was really sort of as people were not just emerging from COVID, but emerging from the surge and this incredible volume. So it took us a while to put together. We, with the help of the American Thoracic Society, had an initial large group meeting that was recorded. And then we had small group leaders or each section leads that met individually with subgroups of each of the larger group to write different sections of the paper. There were 4 of those groups. So we each had a group that we met with. We assembled all of the written work that they had put together and then met again as a large group once we had a pretty good draft and everybody was able to give us feedback on whether or not the draft said what we wanted it to say. It was incredible, the participation. Every person that's listed as an author on this paper participated in certainly the discussion groups, but then even in the editing of the paper, including Dr. Camera Phyllis Jones. So people who are these giants in this work participated, and we were so honored to have those people participate. So it took us, in terms of meeting with all these groups and then actually getting a good report, probably a year and a half.
Monica alluded to this in the beginning. I think there was actually a year prior to that where there was an initial application, and even that was kind of refined. So if you tack on that extra year where, the initial goals of the project, which I was not essentially involved in that phase of it, and the thought process and the speaking to people to figure out what the direction and the goals should be for this document. It's a 2.5-year process. And then, as Monica mentioned, we really were thoughtful about what were the key kind of pillars that we wanted to take home in this manuscript. So you'll see that our results are broken into 4 sections, really thinking about conceptualizing systemic racism and what are those impacts on pediatric asthma. And then we talked about ethical study design and specific considerations for how do we design studies to actually address systemic racism in pediatric asthma. And then our 3rd section is a lot focused on, as you mentioned, Ina, about dissemination, implementation science, and how do we get community-based participatory research to help guide us. And then the last, which I think is super powerful, section is on funding and institutional priorities. So it's really like a call to action, this is what needs to happen in terms of funding agencies and institutions if we're really going to do a paradigm shift and think about, as Monica mentioned, kind of the upstream factors that contribute to disparities in childhood asthma outcomes. So, it's pretty comprehensive. And so it took a while for us to get all of those elements together and to feel like we were doing it justice.
I think for those who haven't participated, myself included, in this broad of a project, I think it really helps to appreciate how much goes into these when you're reading it. So thank you. Okay, let's go ahead and move on to some of the meat of the paper here. So we can start with some definitions of important concepts. Dr. Wong, would you like to elaborate on a couple of those?
Sure. For any listeners who may be new to this field of work, could you expand and elaborate further on some of the concepts that were presented, like systemic racism and redlining?
Yeah, so happy to go into that in some detail. So I think when people hear the term racism, they think of more of interpersonal racism, which is basically, I see somebody who looks different than me and I treat them different. And I think that's a lot of, what historically people have thought of when they thought about like what racism was and how racism was manifesting in the spaces in which we occupy. But I think what we focus on and highlight here is that racism is so much bigger than the interpersonal interactions one-on-one between people and groups of people. And so the concept of systemic racism really helps us to look at what are the policies, the systems, the laws that are put into place, the entrenched beliefs and attitudes that people societally feel. And really thinking policies and laws, things that have been put into place that have systematically put groups of people at a disadvantage compared to their counterparts. One way of thinking about this is thinking about caste. And, there's Isabel Wilkerson has a great book that outlines how in the United States, we have a race-based caste system. It's a hierarchy in which certain social groups of people are systematically placed at a disadvantage compared to other groups of people. And so one example of a policy or a law that was put into place and that has perpetuated this systemic racism is redlining, which you mentioned, Matt. And so, in the 1930s, after the New Deal, after the Great Depression, there was a lot of effort and emphasis on trying to revitalize communities and increase home buying opportunities. And so the Home Mortgage Association were investing in home mortgages in neighborhoods. But in order to determine where they would invest versus not, they created these maps that were focused mostly on the demographics of the people who lived in these neighborhoods, and neighborhoods that had predominantly Black and brown families or newly immigrant families were outlined in red and considered a high risk for home mortgage lending. And as a consequence, people who applied for mortgages who lived in these neighborhoods that were outlined in red or redlined did not get those home mortgages. And so, if you think about like the American dream and what it is that how do we invest in ourselves and our families and our future, our progeny, it's home buying opportunities. It's the neighborhoods in we live in. It's the schools that are in the neighborhoods. It's all of these factors that are associated with, where people live, where they work, where they go to school, that has the potential to influence much longer generational growth, wealth, and health. And so this is just one example of a policy. There are many, many more policies. We outline a bit, and we have tons of references to other books and papers that you can read to learn more about how these factors contribute to the neighborhoods where our children that we take care of, where they live and where they grow and where they go to school, and how blighted communities that are a consequence of factors like historical redlining contribute to increased environmental exposures and increased social risk factors that set these children up for worse outcomes. And we here use asthma as the example that we highlight in this document.
Thank you for elaborating on those concepts further. I also appreciated many of the references that were presented throughout the report for additional reading. My next question is, what would you say are the major messages and key takeaways that readers should leave with after finishing this report?
Yeah, I think, as we thought through this, Stephanie's already mentioned a lot of these, but as we initially thought through this conceptually and then talk to people and move through the paper, certainly the most important thing to take away from this is that if you really want to impact your patients and impact the outcomes and try to use research to understand how to do that, you're going to have to go back to the upstream causes or the redlining that has then led to the differential exposure to different air quality, to differential exposure to poor housing, things that we know impact asthma outcomes. So any research in this area looking at disparities and understanding that systemic racism has really set up this differential exposure needs to do a few things. First of all, it needs to call out racism and systemic racism as fundamental to why sort of how the system is set up to lead to these problems. And then it also on the back end needs to talk about how the results of the work are going to be used to change policies so that we can address or try to change the way the system is set up. So I think that's sort of overarching, incredibly important. More fundamentally, involving anybody who is going to be impacted or is invested at all in the outcome of the research needs to be involved from the very beginning, from the way the questions are designed to try to understand what the real problem is, to metrics of success, and then dissemination of this work, and then how we change the policies. Ethical study design, as Stephanie mentioned, is important, and that really our thoughts working with people who had done this and authors of the paper, such as Nita Thacker, dissemination and implement, and Izaretta Riley. Nita and Izaretta have worked a lot in dissemination and implementation, which is a study design that evaluates not only, sort of the outcomes of implementing, but what are the barriers to implementing? How is it different to implement in one community or one setting versus another? And community-based participatory research is also essential to doing that well and really understanding what those barriers are. I think that broadly outside of the researchers themselves and the research teams is that the funding for this work needs to change. The funding for this work needs to be more comprehensive. And there certainly are groups that have started to do this so that we could pay community members to participate in this research, so that there could be funding for ongoing work to then address policy. We need to think about, if we're going to train people, we will also be training community members. So as people need to check all those boxes to participate in research, how do we do that? How do we do that well? So the design needs to be ethical and thoughtful. Racism needs to be called out, and we need to step forward to fund research like this if we're really going to change policy.
Yeah, I completely agree with Monica. We spend a lot of our time focused on like intermediary determinants of poor health outcomes, like, pest abatement and, smoking cessation and things like that at the individual level. But I think some of our co-authors are at the front edge of the leading edge of some of this work that thinks more about like policies and structures and what we keep talking about as the upstream factors. Like, for example, Tyra Bryan Stevens, who's a co-author, is a pediatrician in Philadelphia. And, she's done a lot of work, not just to remove cockroaches and mice in the homes, but rebuild homes and rebuild communities and neighborhoods that have been blighted because of structural racism, and working with health departments to really invest in that work of rebuilding neighborhoods and making structures sound. Elizabeth Matsui has a great paper that we've also cited that talks about a voucher program that people who lived in low-income communities with poor housing qualities that allowed them to move into neighborhoods with better opportunities and better structurally sound housing, safer neighborhoods, and the significant impact that has had on respiratory outcomes for children with asthma. So I think this work can be done, but it can only be done if we acknowledge two main things, that like we really do need to focus on the upstream causes. And we as clinicians and clinician scientists can't do this work alone. And incorporating, collaborating, working with, social scientists like Keisha Bentley Edwards, who was a co-author, or Kamara Phyllis Jones, who are co-authors who really understand the impact of systemic racism. That kind of collaboration and work in this type of research is what's going to actually make significant impact for our patients and their families.
Wonderful. Thank you. We've heard a little bit about some of those key takeaways, and I like how you framed the 4 different results sections. I'd like to just ask a couple questions looking at table 1 and sort of getting into some of these recommendations. So table 1 from the paper is considerations for conducting ethical research. And I'm wondering if you can talk about 2 things. So one that we've seen play out in pediatric pulmonary is use of race as a variable in pulmonary function testing, right? And I think we're learning a lot more about how those equations, as we've changed our reference values, how that impacts care. And then my second question, something I hadn't seen a lot in research was the concept of decentering whiteness in the evaluation. So I wonder if you can touch on those concepts and how to move forward with those goals.
I think I can take this one. I actually, as someone who was also on the workshop report for removing race in pulmonary function testing interpretation, I can offer that perspective. I think, one of the important things, especially when you think about like race and spirometry and PFTs, is that this is another type of systemic racism where we sort of baked into the system inequity, and we sort of created a tool to evaluate people's lung function and their overall health, and we set the bar different for different people. And then we wonder why the people who we set the bar lower for have worse health outcomes. Well, maybe it's because we set the bar lower for them. Maybe it's because we're not identifying disease at the same threshold as we might identify disease in a white population. And so those two things kind of go hand in hand when you talk about, you brought up decentering whiteness. If we're using white as the reference group all the time, we might be missing things. We might be missing differences across groups. We might be not appreciating how a group being lower or higher in terms of lung function or outcomes or exacerbations. And so I think the goal here, what we're hoping to get people to think more about is when we use race in our research, what does it mean? Are we including race as a variable in our model because we actually think biologically there should be a difference between Black people, white people, Hispanic people, Asian people? Or are we using this as a marker of identifying disadvantage? Or are we including it in a way that we can amplify and overall improve the outcomes for people who historically have been marginalized? And so, all of this is listed in this table, not to necessarily tell people this is what you're supposed to do, but to have people think about why they're doing the things that we're doing. I cringe when I think about 5 years ago, giving lectures to pediatric residents on how to interpret PFTs and the statements I would make about, and we always adjust for race. And why did I do that? Because we always adjusted for race, right? And until we stop and think about why are we doing that? What does that mean for our patients? What is the long-term outcome? We're just going to keep doing things that we've always done. So that's the big push here, is to be more thoughtful about conducting these research studies, about designing these research studies, getting perspectives from different disciplines as we put these projects and these studies together so that we really are not further disadvantaging populations of people.
Thank you. And I think that's a great place to highlight a December paper from the Blue Journal that came out comparing race neutral versus race specific spirometry for evaluation of childhood asthma from the ECHO cohort consortium through one of our ATS journals.
My next question is related to something we mentioned earlier. What strategies have either of you employed, or what advice would you offer in designing projects that better engage community partners and community stakeholders in this space?
So I'm going to start, and then I'm going to defer to an expert who has done a lot more of this than I have, which is Dr. Lovinsky-Desir. So I think that, it is so important to, as we've already talked about, think about the fact that if you don't involve the people who are invested in the outcome of what you are doing in the work, in the questions or the research you're going to conduct, then you potentially aren't going to be asking the right questions. You won't, again, have the right metrics of success, or at least metrics that are meaningful to the people that you are working with, whom you are working. It also is possible that work will then continue or perpetuate inequities that already exist if you don't talk to people about sort of how you're going to conduct your research, how you're going to ask your questions, what you're going to implement to try to improve things. I think, what we talked about a lot is that in order to work with communities, you need to build trust You can build trust by treating those people as equal members of the research team. And that means certainly through respect and understanding that they bring a level of expertise that a person without lived experience cannot bring. It also, ideally, if the funding is available, is paying those community members to participate at a level that is equal to what you would pay other co-investigators, a further demonstration of the value of their input. And then making sure they have equal say, not just in how the research is designed and conducted, but then how you're going to disseminate those results, how that might apply to future change. Communities, we are hearing over and over, are very tired or becoming tired of what people call research tourism, or I'm probably not using the right word. Stephanie will have the right word, but where people come in, ask questions, find what they feel to be the answers, and then leave and never help the community address any of the problems that were identified. So involving the communities from the beginning by building trust and respecting their input, I think, is where I would start. And then I will defer to my expert, or to not my expert, the expert. I apologize, Stephanie.
I'm not going to call myself the expert. There are a lot of other people with much more varied levels of expertise in this topic and who have been doing this all for a really long time. But I will say, I'll use an analogy. Think about like the hardest patient you ever treated with asthma who had like terrible outcomes. And like the first time you met them, you don't walk in the door and say, hey, I know how to solve your problem. I know you've been in the ICU a million times. Just take this medicine, do this, and it's all going to be better, right? The best outcomes come when you develop a relationship with the patient, when you understand what are the factors that are going on in their lives that are contributing to this difficult time that they're having with their asthma, or fill in the blank, whatever other problem. And it's through that long-term relationship building that you have the potential to actually make a significant impact. And I think this is no different. Engaging with communities in research is the same. So my advice to somebody who's kind of at the start of their career or pivoting towards this type of work is, there are tons of grassroots community organizations out there that are made of people who really want to make a difference. And your expertise in the academic arena could be very valuable, but you could also learn a ton from the stuff that they've already been doing and what's happening in that community. So start by joining their meetings and not talking and just listening and understanding what the problems are. What are they struggling with? What are the questions they're trying to answer? And, in that, when you do more listening as opposed to lecturing or talking, you position yourself to be better equipped or better prepared to actually address things that are meaningful to that community or that group or that organization. A number of years ago, probably 4 or 5 years ago, I happened to sit on a panel with someone. I said, oh my God, you're doing amazing work. I'd love to hear more. And joined one of their meetings of this community group and really was just listening and just trying to figure out, like, is there a space here where I could leverage some of the skills that I have to help them do the work that they're doing? And, 4 years later, we've got funded research projects together, and we're engaging students in environmental justice research. And it's probably one of the most rewarding lanes of my research that I do. And it's because it's not all driven by the metrics of success that we often think of in our academic institutions, but it's really measured in how am I creating impact for the young students who are engaged in the research and the community group that is partnering with me on this work. And so, I think it's critically important to recognize that these aren't necessarily one-time, one-off, quick relationships, that it really requires commitment and investment in building relationships with communities and community partners and people who, if you really want to make significant impact.
Great advice. Thank you both for sharing. On the topic of research funding, can you share any strategies in regard to obtaining funding for studies in this space?
Yeah, I think this can sometimes be challenging and tricky. I will just say that, found out that we got a small pilot grant that was an institutional, it's like from our department, seed funding to start the kernels of a project with a new collaboration between myself and one of my social scientist friends to look at energy insecurity and pediatric asthma. Energy insecurity being a social risk factor that sets children up for poor outcomes, but hasn't been studied with asthma. And for that specific project, we had to start small because nothing has been not a lot has been published in that area. This is a brand new collaboration with this new partner. And so we went for a teeny tiny pilot project, pilot grant. And the goal is to kind of like a snowball, roll that into larger funding. And so I think that for me has been the strategy as it's been the same with the project that I mentioned to you before. It's started with a teeny tiny pilot where we can, establish relationship, get some money to do a little bit of pilot work. And then, I think the outcomes help to demonstrate the need for additional support. And so that's what I've done. I don't know, Monica, if you have other advice.
Yeah, it's funny. I have an actually identical journey. So we had built our asthma program, and then I got a pilot grant from the Department of Pediatrics, and we did a needs assessment. We did that needs assessment by calling families who had been in the hospital and by having meetings where we met with community members to try to understand where the gaps were in care. And we learned that we really needed to take our education into the places where those families lived, so into homes, into schools. So we then worked with our the Colorado Department of Public Health and the Environment. They have funded two very large projects. One is our asthma home visit program. Another is a school-based asthma education program. In the at-home asthma work, they've continued to fund that. And then that has led to several different funded projects, including qualitative work. And now we potentially are going to collaborate with Tyra Bryant Stevens to do some true big time home remediation. The school project with school asthma actually then was pivoted into a large NIH grant that was dissemination and implementation of the school education throughout the state of Colorado with community advisory boards and lots of other things through the Decipher program. So if starting small, starting to understand where the problems are, starting to understand where you think you can make an impact and where communities want you to be helping and partnering with them, I absolutely agree. That's where you start this work, and then you can take it where it takes you, really.
Monica, can you say a little bit more about your experience partnering with local public health? I think that's something, when I hear that as a clinician and not a researcher, I think that is something that some folks it's something you could easily take locally, especially in a state where we are in Maine. It's everybody knows everybody in sort of a smaller, more rural state. And so leveraging those connections locally, if you're not in a larger academic center, can you just talk about your experience with that?
Yeah, it has been an incredibly rewarding experience. So we started working towards this grant. And as you work with your Department of Public Health, they will ask those people who have applied for and potentially gotten, but even they can just learn that you have expertise in this area to participate. So we've participated in the Healthy Housing Coalition, for example. That came partially through applying for a grant, but also through partnering with a group in another town in Colorado called Fort Collins. And we were able to build a list that is now used statewide for home assessments and other home visit programs. There is now also, I know many of your states already have this, but we just passed a bill where community health workers could bill for their services. We participated in that advocacy with the Public Health Department, with our own Governmental Affairs Department, and in partnership with several federally qualified health centers. So it can be with your Department of Public Health. It can be just in partnership with other organizations. But through that, there is a state registry for the community health workers, and we are working with the Department of Public Health to talk about what that might look like in terms of their education for pediatric community health workers, for those who want to specialize in things like asthma. And then I'll take it even further, there's this exciting opportunity through AmeriCorps, and AmeriCorps is actually willing to pay for half the salary of a community health worker to do essentially an apprenticeship. So we're working with funding from actually a local, sorry, I'm taking this sort of even further. Through that work, we worked with a local, Maine was one of the Medicaid payers in the state of Colorado. They have helped us pay for a community health worker that helps with inpatient to outpatient transitions. And we are now going to be able to fund an AmeriCorps apprentice who can work, and they will pay half of their salary. At the end of that year, AmeriCorps has somebody who has been trained to be a community health worker with lots of experience. They will be registered through the Department of Public Health because it's in partnership with them. This is actually a HRSA funded project. So you learn all of these things by just starting small and participating in the Healthy Housing Coalition, and then it goes from there.
That's great. Thank you. As we're sort of wrapping up, I want to give you each opportunity. Is there anything from the report or any concepts that we haven't touched on that you think are really critical that you want to get across to listeners?
I think one of the things that we hadn't talked too much about, but that I think was really illuminating for me in our discussions with our community health workers, research coordinators, and parent advocates, was about in the design of clinical research studies for childhood asthma, something as simple as the timing of study visits, how comprehensive, how long, how time consuming the study visits were, and how that potentially deterred certain families from engaging because they had to go to work, because they had to, do other things, and how potentially that might create some bias in the sample that we actually collect from. So I think that's just like a teeny tiny nugget that's like buried in there, but I think is something, again, as I was talking about, we want people to think as they're putting these projects together about like real practical factors and like real important questions. And that's just one thing I think people could take away is like, as you design a study, particularly if it's focused on addressing systemic racism, thinking about what are the burdens and demands that we're putting on patients and their families to help develop the data to support this kind of work.
I think that one thing that I would add is a project that we have spent a lot of time on here, and I know people across the country are working on, which is if you're going to work within your own clinical system to do research, you need to have good data. So you really need to think about how your own healthcare system is asking questions about what is the race, ethnicity, ethnic background, and language of the patients that you are seeing. That can be particularly complicated in pediatrics because most electronic medical record systems are set up for adults. And so, for example, is the language in your system the language of the patient or the language of the caregiver that is bringing them to the visits? So just understanding how that data is collected, we have learned that how that data is collected for clinical care looks different than how that data is collected potentially by researchers. And so then when you try to look at your outcomes and you're matching race and ethnicity, sometimes it doesn't match. So you want to think very fundamentally about how data is being collected, especially when you're conducting health services research and clinical research, not just within your own research study, but how it was collected by your own healthcare system. And then I think the last thing that I would say that I learned is there are incredible people doing incredible research in the American Thoracic Society. And it is so fun. This work took us a long time, and it was absolutely sometimes just a work of passion, but it was really fun because these people are incredible people and they have so much to teach me, certainly. And I think everyone can learn from experiences, the things that you just, when somebody casually says something and you think, oh my gosh, that never occurred to me. And it's so important. So participate in these workshops, think about how you can participate, and you will learn so much. It is such an incredible experience.
I completely agree. As someone who's spent my entire career in one academic institution, and I've lived in the Northeast my entire life, it has been such a pleasure to make friends who have similar, goals and similar outlooks on things in our academic career from across the country through participation in workshops like this. And I call Monica my friend now, and that would never, ever have happened if we hadn't participated in this workshop together. So I am so grateful to have been part of this experience. And I definitely, as Monica mentioned, highly recommend for people to engage in these types of workshops.
Awesome. Dr. Federico and Dr. Lovinsky-Desir, thank you both for your time and a really lovely conversation. If you haven't already, please check out Research Priorities in Pediatric Asthma Morbidity, Addressing the Impacts of Systemic Racism on Children with Asthma in the United States. This was published in the Annals of the American Thoracic Society in October 2024. Thank you for listening.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.